And it's activation. Can you hear me?
صدای کم بلند کردم.
Can you please confirm if you hear me and so you can see my presentation?
چه تصویر من نصفه میاره تصویرش نمیده. Dr. Ingrid? Hi, Dr. Ingrid. Can you hear me? ظاهراً ولی دکتر اینگرید صدا ما رو نمیشنوه. چرا نمیشنوه؟ بازه. شاید از اینجاست. دکتر اینگرید؟ Dr. Ingrid, can you hear me? چرا صدای این قطعه؟ این درسته؟ درست.
اوکی چون انترسانت بود اینترنت تو تصویرش نکنم میخوام بهش بگم
Hi, Dr. Ingrid, can you hear me? Unfortunately, Dr. Ingrid doesn't respond. Would you please, Dr. Ingrid, if you can hear me, I don't have your voice, but if you hear me...
Okay, can you hear me now?
Yeah. Now
okay,
it's everything is okay.
I had to log out and log in again, sorry.
Share your, open your PowerPoint on the desktop, on your desktop,
okay,
and then
I
share
will.
in the PowerPoint.
Okay, I will, but then please confirm if you can see my slides, because when I open and share the whole desktop, then I stop seeing you. Then I don't see you and I don't know what's, let's say, going on in the background. Okay? Can you see the presentation?
پاورش رو چی باز کنه رو دسکتاپ و شیر اسکرین رو از اینجا پیدا کنه بزنه.
Dr. Ingrid, please open your PowerPoint on the desktop and then find the share screen in the upper bar under the type, under the clock. Share the screen while your PowerPoint is open.
Hello again. I think that I'm being logged out from this Sky room after a few minutes because I could hear you and you couldn't hear me, and I was sharing my screen. So I will try to share again.
Now everything is okay, but we should have your slides. Yes, share it again.
Yes, but I shared it. The thing is that you couldn't see them because I got some kind of message saying publishing media failed. This can be due to network connectivity issue, and I don't have a problem with my network here.
Yes.
So maybe something on the way. So okay, I will try to share again. Okay. There's something wrong because when I want to share, it does not show the window with PowerPoint. Just I will try to log in from another browser because there is some kind of error here. Sorry.
Browser. میگه میشه دوربین کامرا رو برای من فعال کنی؟ برای من انگرید میگه Now your camera and mic is on.
Okay, can
Yeah.
you hear me now? Can you see me now? Okay. I logged in from another browser, and
Yeah.
now I will try to share the screen again. Okay, now it should be better maybe. Okay, I think you should be able to
Yeah. It's
see
okay.
the presentation now. Okay.
Thank you. We have your slide now.
Uh-huh. Okay. Huh. It disappeared. It's strange.
Yeah.
No. Now it's back. Okay.
It's back.
Good.
Good.
Okay, good. Okay. All right. I hope it's going to work.
I hope so. At first, I will have a brief introduction, although all my colleagues know you well, and you are well known in our society in Iran. I should mention it again. It's 11 o'clock in Iran time, and we can open the program. Professor Ingrid Rosalio Kalinovska is the head of the Department of Dental and Maxillofacial Radio Diagnostics of the Medical University of Lublin, Poland, and serves as the Vice Dean of the Faculty of Medical Dentistry of this university. She is a specialist in radiology and diagnostic imaging. Dr. Ingrid has more than 250 full papers and more than 350 lectures in different conferences, and she is a supervisor of 14 completed PhD theses and 4 ongoing PhD process as well. And she is very expert in dental maxillofacial radiology, especially in ultrasonography. We wish she can share his knowledge and experience with us, with our colleagues, and we are here to listen to your scientific program. Thank you.
Thank you so much, Dr. Bashizadeh, for this kind introduction. I would like to thank everyone from the university for this honor of being visiting professor. Of course, unfortunately, to the times that are now, it's not possible to meet live in Iran and Tehran, but fortunately we have overcome some problems with internet connection, and I hope that despite this distance, let's say location, we can still be together for this lecture. I would like to thank also very much Dr. Dariusz for the contact and for approaching me with a kind invitation to deliver this lecture and to fix all the issues with the date and the timing of this meeting. As already mentioned, it's 11 in Iran, but we are still this week in the Central Eastern European time, so it's 9:30 here in Poland, and now I will try to share my presentation with you. It's been running, so I don't know what happened right now. Okay, I will try to resume it, and hopefully you will be able to see the whole slides on screen, not just the preview of the slides, and also my marker on screen. So, as I was kindly introduced, I'm based in the Medical University of Lublin in Poland, and of course, Lublin and Poland is not as historical as Iran, taking into account the thousands of history of Iran, Persia, but in Poland, Lublin is also a very old city. We received the city charter in 1317, so our city challenging because we had to move during the pandemic between the first and the second lockdown. And so we had to adapt the building, which was not designed for COVID, to running face-to-face classes in dentistry, in dental hygiene, in dental technology, and also radiography in these new conditions. It was also a very big challenge for me, as in the summer of 2020, I was appointed Vice Dean of the Faculty of Medical Dentistry in our university. This building is the second most important for me in teaching, as this is the Center of Medical Simulation, and it's one of the newest and most contemporary centers of medical simulation, not only in Poland. In Poland, it's definitely the best, but also in Europe. For example, the ambulance that you see here, it's not because there was an emergency. It's part of the equipment of the building so that the students can train how to save, rescue patients already in an ambulance before they start clinical classes. And the whole third floor of the building is dedicated to teaching of dentistry. My classroom, including computers for students, is also located in this floor. And we have got the simulators, the phantoms, in this floor as well for preclinical teaching. And these two buildings, when you visit us, you will see that they are definitely walking distance because they are separated only by this building, which is the building of a faculty of pharmacy. And just to give you a glimpse of our teaching, these are our students performing during phantom classes. And last year we also purchased 3 haptic simulators with sophisticated software for teaching in preclinical environment. And since I'm trained as medical radiologist first, it was really fun for me to try one of these haptic simulators and, for example, fill in a cavity first, prepare a cavity and then fill it using this software. So as mentioned, this is our building. There are clinics in the back building and in front, and radiology is situated in level 02 in the frontal building, and you can recognize immediately that it's radiology because in comparison with the other floors, we need to have dimmed light, and we use some screens to cover the windows. This is a picture from our clinics in the new dental school. And here you can see some images from my department. Fortunately, they were taken before the patients started arriving, because these days we've got hundreds of patients in the dental school and over 150 on daily basis just in radiology. So let's move on to the ultrasound, which is the topic of our lecture today. A brief introduction to the principle of ultrasound, because I'm sure that the participants of this webinar have different level of expertise, and some of them, they may be beginners in ultrasound. So ultrasound uses physical properties of acoustic waves, hence sound, which is technically speaking frequency over 20,000 Hertz. However, in diagnostic imaging, there are used acoustic waves characterized by frequency from 2 to 20 megahertz. And in some imaging studies which are focused on mucosa or skin, very high frequency probes with frequency up to 50, 100 megahertz can be used. So we can compare the ultrasound to what bats and dolphins can hear. And this is the range of human hearing, of course, taking into account healthy human. The principle of ultrasound is based on a wave emitted by a transducer called also a probe. And the probe emits the original wave. And just as any wave, like if you go to beautiful mountains in Tehran and you shout and the echo will come back to you, this is the same idea as the ultrasound, because when the wave encounters some kind of object, it's being reflected and comes back to transducer as an echo. On the other hand, Iran is also surrounded by a beautiful sea, and just as you go to the seaside, you see waves, and the waves in the sea are subjected to the same kind of physical properties as the waves of sound. The difference is that the sound does not need any means for propagation of this wave. Well, this is a simple question, but really essential. What do you need in order to perform an ultrasound scan? Of course, you need some kind of ultrasound unit, an adequate ultrasound probe, some ultrasound gel, examination gloves, and protective wearing clothes, especially in case of COVID pandemic, but not necessarily in these times, also just to protect yourself against common cold or just influenza. Examination bed or chair, and this is not always so obvious. In my department, we use an examination bed because we don't perform any intervention surgeries with us, and the ENT bed also allows us to change the position of the patient from sitting to lying down to recline the head backwards, etc. As to move the patient. Yes?
We can't see your slides one after another. You don't show them in the desktop?
I show them. I'm at slide 11.
We are on your first slide. on our screen.
Oh,
yes.
really? Oh,
Yeah.
I'm sorry, but I've been changing them, and I'm in slide 11 by now, as you can see. Can you see? Oh, I can't see. Can you see now? I went all the way to slide 11.
It's
I'm
now
sorry.
another slide on the screen. What you need in
Okay,
order to
so
perform. Yeah.
what we can do is that we just go with a preview of the slides instead of a whole slideshow, because otherwise it doesn't work probably. Let me see if there is anything I can do otherwise for you. So I've been telling you, but you haven't seen it. So let's have a look. I'm sorry, but I didn't realize, because I was changing the slides. So just a brief glimpse of my city and the buildings I was telling you about, the dental school and the Center of Medical Simulation. Our students in the Center of Medical Simulation, haptic simulators, then the clinics in the dental school, and this is my department. And in fact, since I've just been talking about the examination bed, can you see my pointer? Can you see my arrow on screen?
No, I can't see it. The pointer is not on. But is it real?
Because the pointer is on only when I go to full screen.
Would you please put your PowerPoint on a slideshow?
Yes, but then they do not change.
Yeah. We can't see
now
your
I'm
pointer.
in slideshow.
Yeah.
I'm not. I'm in slideshow. Can you see the slideshow?
No.
Which slide can you see? Can you please confirm?
Would you please press Shift and F5?
Okay, I pressed Shift and F5. What can you see?
It's not on the slideshow.
It is. I can. I mean,
for me.
I can do. I can take a picture and send it to you, so that you see what I have on the screen, and it's like full slides. I'm sending it to via WhatsApp right now. So
you can continue, you can continue, but we don't have your pointer.
Okay, that's okay. So otherwise we can't continue if. Now maybe you can see my pointer somewhat.
Yes.
Can you see something?
Yes, I can see it.
So I think we just must continue. I'm sorry, in this slides preview, because when I share the whole screen, then you don't see the slides changing.
Yeah.
Because I really did. You know, it's this one. It's slideshow, and then when I click from the beginning or from the current slide, you stop seeing my slides. So there's something wrong here. Okay, never mind. Let's go on with the preview.
Yeah.
So as mentioned, these are some pictures from my departments, and this is the examination bed I was telling you about, the one for ENT, not a regular dental chair. And we've got one more chair, which is designed, in fact, for taking blood samples, but this can be useful as well for examination and the patients in the sitting position. So I mentioned this, and then I was telling about the principle of ultrasound, and then we went to the examination bed and chair. Then we need some bed linen and towels to cover the bed and the patients to protect from ultrasound gel. And this is quite important because this is an ergonomically adjusted chair. Performing ultrasound can be quite demanding on the operator when you have to be for a few hours with your hands moving across patients' surface skin. So the chair is very nice for you. Regarding ultrasound units, of course, I do not work with any company. I do not advertise any company. I just wanted to show you an example of ultrasound units, the variety that you can have these days. So, of course, there are some very sophisticated machines that allow you to use a lot of different modes for scanning, and there are very plain machines. In fact, nowadays it can be just a transducer that you connect with some kind of mobile device, for example, a tablet or even a mobile phone. But of course, these devices have different application just for very easy cases, mostly on site in an ambulance, on site of car accidents, on a plane, rescue plane. They can be used by family doctors. So, of course, if you want to use ultrasound for research, for more sophisticated purposes, you need a bigger and unfortunately more expensive machine as well. The machines are fitted with a lot of knobs, buttons, and nowadays also touch screens. So I would not talk about knobology anymore, but let's call it touchology. But it's beyond the scope of our lecture, so you need to practice with a single machine that you've got in your department or during some hands-on, for example, to get familiar with all the settings. I would only like to underline that ultrasound is a dynamic examination. So it means that during the scan you adjust a lot of settings. Of course, there are some auto settings, some default settings, but it's you to decide, for example, on the gain of a machine, on the contrast, on the brightness, on the depth of scanning, zoom, etc. Well, again, ultrasound is a dynamic examination, so you keep on moving the probe over the surface of the skin or mucosa of a patient, covered with ultrasound gel, or in case of time you don't really need it because it's already moistured with saliva. It's less demanding for us to perform the examination, the patient lying down with the head tilted a little bit backwards and also rotated to the contralateral side. So if you wish to examine right parotid or right submandibular gland, please ask the patient to tilt the head to the other side. Of course, again, it would be nice to have a video demonstrating the performance of ultrasound, but I'm afraid that owing to our internet connection it might not be a good idea, so I'm showing you just an example of static images of my colleague from the department, Dr. Kasia, who granted her permission to use the photographs in our presentation. And for every kind of lesion or an organ that we want to examine, we shall place the probe in transverse and longitudinal positions at least, and document the lesions with the capture of the screen. We freeze the image and then we save the image or save a video. Otherwise, we do not have any record from the scan because the whole study is not recorded on usual basis. For the ultrasound gel, it's also mandatory. I'm sorry for all these red marks because this is the slides preview and not the slideshow, but still I think that in radiology the images are just the most important. So the ultrasound gel is important in examination for two purposes. First of all, it eliminates gas, air from the intersection between skin and the probe. And ultrasound is reflected off gas. That's why it does not perform very well, for example, in lung studies or air-filled sinus exams. So this is one reason for using the gel. And the second one is that we smear the patient, and it definitely makes the movements of ultrasound probe over patient's body easier for us. In case of small lesions, for example, when I examine small vascular lesions in the lips, I use the so-called distance. It can be a gel pad, but these commercially used gel pads, they are very big, like 6 centimeters in diameter, 1 centimeter in thickness. So you can imagine putting it on patient's mouth and trying to see a 1 millimeter lesion through this coupler, and then try to hold it. One hand for the probe, the other hand for the knobs and buttons on the ultrasound machine. So you need a third hand to hold the gel pad, but sometimes you are on your own in the ultrasound room, so it doesn't make sense. So what we do, we put some small jellies, sterile single-use jellies on top of a probe and fix them, and this produces this effect of acoustic coupler, and this increases the quality of the image in the near field of the ultrasound. What you can do with ultrasound depends to a very large extent on the probe that you have, and there are definitely hundreds of ultrasound machines, types of ultrasound machines in the world, and different probes for different purposes. This is an image which comes from an older Polish textbook, but I like it a lot, as it compares the field of view of different probes within the same organ. So in this case it's liver, but the liver is imaged with different probes, and for example, linear probe, convex probe, and the sector probe. So each probe is different. The convex probe, used mostly for abdominal studies, will demonstrate the organ deep down in the body, so you can see almost the whole liver here. The sector probe will also have a very big depth of penetration, but a more narrow field of view, so this one is suitable, for example, for intercostal approach, for heart, for echography. And this is a linear probe, which gave you just this tiny part of the liver, but on the other hand, the resolution is much higher than in case of the other probes. So these are the probes I use in my device. Both of them, they are linear array probes, so you can see that their footprints are flat. One of them is bigger, the footprint is bigger, and I use this one for extraoral examinations. The other one has a smaller footprint. You can compare the size of both probes. And this one is called hockey stick, because it does really look like a stick for playing hockey if you do play it. I don't, but it definitely resembles the hockey stick. And these probes are used for intraoperative scanning in surgery, but we use them intraorally after covering with plastic disposable foil. In ultrasound, we also use the Doppler effect that you know perfectly from school, from physics, from the change of sound of the ambulance coming and going. And it also applies to the blood moving in the blood vessels in human organism. Another very important feature these days, it's elastography. So this is a kind of objective palpation, I would say. Normally, when we palpate, we assess whether a lesion is firm or soft. If you want to press a golf ball, I'm sure that if you are a strongman, you might be able to do it, but otherwise, if you press it, you can't break it. But if you've got this jelly tomato I got from my daughters for relaxation, when you press it and you squeeze it, it changes shape because it's just very soft. In fact, this is my second tomato because with the first one I squeezed too strong and it just broke and spilled on my keyboard. So in fact, I was even more stressed instead of being relaxed. But nevertheless, when the lesion changes shape, the ultrasound machine can pick it up either quantitatively or qualitatively. We've got the so-called strain elasto, in which just the maps of hard and soft areas are being demonstrated on the screen with a color coding of high stiffness and low stiffness. Please bear in mind that in some machines it's exactly the opposite. So the stiff areas can be blue and the low stiffness areas can be coded with red. And we've got also the quantitative shear wave elastography, in which the stiffness of the tissues is based on the Young's modulus of elasticity. And in many applications, just like breast ultrasound, now it's indispensable to use elastography for differentiation of lesions. Let's move on briefly to ultrasound anatomy. And please remember that when examining from the extraoral approach from underneath the oral floor, we look as if the atlas of anatomy was upside down. So what we can see is the skin, the closest to the probe, then subcutaneous fat tissue, then anterior bellies of the digastric muscles, the mylohyoid muscle, the genia hyoid muscle here, and the large genia glossus muscle. On both sides bilaterally, you've got the sublingual glands. And when we teach, it's very often that we compare this image to like Mickey Mouse with ears and eyes of Mickey Mouse, and this helps people to remember the anatomy of the oral floor. As mentioned before, we have to keep on moving the probe from the symphysis of the mandible all the way to the hyoid bone, and on the way you can see the same muscles, but as you know, the anterior bellies of the digastric muscles, they diverge from the midline. So here we can see them a little bit further from the midline, still the mylohyoid muscle, and still the geniohyoid, the genia glossus muscle. As mentioned as well, you need the transverse and longitudinal sections of the images. So this is oral floor longitudinal with the same structures, skin, subcutaneous fat tissue, then there will be mylohyoid muscle, geniohyoid muscle, and the genia glossus muscle. This picture from anatomy is once again turned upside down. And this is oral floor longitudinal, but a little bit oblique from the midline to demonstrate you the anterior belly of the digastric muscle. For the normal submandibular glands, it's homogeneous with densely packed echoes, and in fact the internal structure of glands such as submandibular glands is similar to normal thyroid or normal testis. Parotid can be a little bit different in echogenicity due to higher content of fat tissue. So this is the submandibular glands. This is the posterior free ends of the mylohyoid muscle. This is the hyoglossus muscle, and between the two of them, you search for the submandibular gland duct. And this is not in any textbooks of anatomy, but it usually looks like a sandwich to me. So you look for the duct sandwiched between two muscles. And then it's also compared to a Pac-Man. If you ever played this game, I haven't to read about the Pac-Man because everybody keeps comparing the submandibular gland to a Pac-Man, trying to eat up the posterior border of a mylohyoid muscle. And this is submandibular gland longitudinal, so it's mandatory to demonstrate the whole gland. And of course, we have to remember that we don't examine just one gland, we examine both glands as for comparison. For the normal parotid gland, it's larger, that's submandibular, and similar, but as mentioned, it may contain some more fat tissue, thus the echogenicity will be a little bit higher. So this is normal parotid gland in longitudinal direction. Again, on top it's the skin, it's the subcutaneous fat tissue, and so owing to image attenuation, but by fat tissue we may not see the deeper areas beyond the parotid glands. For the parotid gland transverse, here with a color Doppler, it's important to observe the blood vessels that pass through the parotid gland and make a difference between superficial and deep loads of the parotid. To the front, there is the mandibular ramus, and on top the masseter muscle. This is the anterior extension of the superficial lobe and the deep lobe. And this is postacoustic shadowing behind the posterior cortex of the mandible. And you can see where the probe was placed by looking at the marker, the transducer on the so-called pictogram. And what is especially important in case of parotid glands, it's the course of a facial nerve. We can't see the nerve really crossing the glands. See, it's the masseter muscle, then it's the mandible, the medial pterygoid muscle in the inner side, and we've got two important blood vessels. One which is more superficial, it's a retromandibular vein, and the other one a little bit more protected, deeper inside, external carotid artery. And you have to remember that the course of the facial nerve is around these blood vessels. So it's important also in evaluation. Apart from salivary glands, we also examine the muscles of mastication in ultrasound. For example, the masseter muscles, again on top skin, subcutaneous fat tissue, and then the muscle itself on top of the cortex of the mandible, and postacoustic shadowing, so we can't see the mandible. Where can we apply ultrasound in dentomaxillofacial radiology? I would say it's a very vast area. As mentioned, salivary glands, but also lymph nodes, muscles, skin and subcutaneous fat tissue. If you have got dedicated probes, tongue, blood vessels, and to some portion also the TMJ. As far as different lesions are concerned, it can be developmental anomalies, inflammations, salivary stones. Oh, sorry, this is cysts, tumors, trauma, foreign bodies, masseter hypertrophy, other lesions as well. We use it for guidance for biopsy and punction, and also for ultrasound-guided interventional procedures, like, for example, steroid injections to the TMJs. Now it's quite a traditional approach, but everybody starts with developmental anomalies when talking about any kind of system or organ. But in fact, developmental anomalies of the salivary glands are not that often. What you can see most often in many patients, it's a little portion of superficial lobe, but it's completely separated by fat tissue from the superficial lobe. It lies on top of a masseter muscle. In some patients, they come to ultrasound with a temporary diagnosis of a cheek swelling, but it's not cheek swelling, it's just accessory parotids. The other way around, agenesis of salivary glands is extremely rare. I don't have a case like that, so here I'm showing a case of from literature with missing parotid glands and missing left submandibular gland. In comparison, the thyroid is normal. Ultrasound imaging is also extremely useful in diagnosing of stones, because all the stones in our body look the same, whether kidney, bladder, gallbladder, any calcifications in soft tissues, and also for the salivary stones. They are hyperechoic because they are very dense, and they produce this post-acoustic shadowing because the beam is reflected off the anterior surface of the stone. Smaller, less calcified stones may not produce acoustic shadowing. And another sign is concomitant widening of the ducts in the glands. And this is an example of an asymptomatic female who had CBCT before orthodontic treatment, and there is incidental finding of a salivary stone in left submandibular gland. And then we confirmed it with ultrasound. The stone is in the hilum, hyperechoic with post-acoustic shadowing. And this is an example of another calculus with widening of parotid duct on top of the masseter muscle. And here is also a calculus with very large dilatation of submandibular gland Wharton's ducts. Mucocele is also frequently visualized in our practice as the patients are referred to our oral surgery and oral medicine clinics with different lesions, the ones that general dental practitioners cannot cope with. And mucocele develops where mucus secretion gets beyond salivary gland parenchyma. It can affect small glands spread in the mucosa and the tongue and cheeks, oral floor, etc., but also sublingual glands. Some of them, they are called ranula because when ranula breaks from sublingual gland and enters into submandibular space under mylohyoid muscle, we call it like plunging ranula. So there's a small mucocele in tongue on the left side, anechoic or low echogenicity, well limited lesion. This may be a little bit strange image because there was a cheek mucocele, a very small one, and I couldn't pick it up, so I put my finger in a glove under the lesion and then the probe on top of the lesion, so it was very easy to be found now. So this strange appearance is just my glove and my finger, so don't mind that. The mucocele is perfectly visible. And another mucocele is an anechoic lesion. And this is a ranula. This is a large plunging cysts. We do not observe them very frequently in Poland because they have been diagnosed in HI positive individual and patients with AIDS, and in Poland the prevalence of AIDS was not as high as in many other countries in Europe, and now when the infection is very much under control with chronic course, and the patients do not present with the lymphoepithelial cysts anymore. But please remember that if you see any cysts or cystic lesions within the glands, especially parotid gland, please think first of an inflamed lymph node, because parotids are full of intraglandular lymph nodes, and then they can enlarge, they can go anechoic in course of infections. But if you have multiple cysts in parotid, think of lymphoepithelial cysts. If you have single cysts, then also take into consideration the Warthin's tumors, as the real true cysts are very rare in the salivary parotid glands. For acute sialadenitis, in case of mumps, the clinical presentation is so characteristic that you don't need any ultrasound or any other imaging studies. For acute sialadenitis, because of edema and hypervascularization, we will have increased vascularity in Doppler, color Doppler, and power Doppler imaging, and also decreased echogenicity of the glands. The problem may be related to a calculus, and then there will be also a widening of parotid ducts, but there may be inflammation without calculus, with some mucous plugs, for example, and then there is a widening of the ducts, parotid duct as well. For inflammations which progress to an abscess, there will be a low echogenicity interior surrounded by the thick capsule. The capsule will demonstrate a lot of blood vessels again during the increased vascularization, while the interior filled with pus will not demonstrate the color Doppler signal. And this is abscess of the right parotid gland, information again, the areas with low echogenicity and hypervascularization of the gland. We also examine patients with chronic sialadenitis. It can be due to bacterial infections, autoimmune diseases, radiotherapy, and also treatment with radioactive iodine. And in chronic sialadenitis, the striking feature of ultrasound image is increase in echogenicity of the glands due to fibrotic changes, and also we can observe a widening of ducts. So in this case, this was chronic sialadenitis in left parotid gland with very much increased pattern within the glands. For the Sjögren's syndrome, ultrasound is also very helpful in determining what we previously determined by means of sialography. And in fact, I don't know what it's like in Iran, but in Poland, no one performs sialography anywhere in any radiology center, either dental maxillofacial or medical radiology. That's why we shall rely on ultrasound for at least initial diagnosis of a Sjögren's syndrome, and it will demonstrate the same lesions as in sialography previously, which was due to leaking of contrast outside the ducts into the parenchyma, producing the snowstorm appearance with contrast medium. And we see corresponding lesions in ultrasound as many anechoic lesions affecting all major salivary glands. And in fact, these four pictures, they come from the same patient, male. I remember this patient very well because I was not able to explain to him that this was autoimmune chronic disease, and there was definitely no treatment that could restore his glands back to the normal, only the treatment for the symptoms. Another patient with Sjögren's syndrome In ultrasound, as you can see, the vascularity is not as high as in case of acute inflammation. Cyanoses are other enlargements of salivary glands, not due to inflammation and tumor. And here it's very important to take medical history. For example, this was female patients suffering for diabetes type 1 for a very long time. Let's move on to some tumors. The most common of the salivary gland tumors, it's pleomorphic adenoma, typically located in the parotid, and then we've got a small lesion which does not show vascularization. It can definitely mimic a cyst. You can observe that the echogenicity is slightly higher than in case of a cyst or inflamed lymph nodes, but it produces post-acoustic enhancement. So this is the opposite of post-acoustic shadowing. The signal is increased following passing through a lesion which is a low density, thus do not reflect the whole ultrasound beam. Pleomorphic adenomas are also well limited unless they have some daughter areas, and then they may be polycyclic, and it's called pleomorphic because with larger tumors the image will be very heterogeneous, also with calcifications, with areas of degeneration, and then it will be easier to differentiate it from other tumors, but small ones are difficult for diagnosing. Elastography can be used. There is a study from my Polish colleagues, but the conclusion, at least at that time, was that elastography was not as definite in differentiation of head and neck salivary tumors in comparison with breast or thyroid glands. The Warthin's tumor, I have already mentioned, the lesions with cystic components. There was a large Warthin's tumor in left parotid glands in a male who has suffered from swelling for some considerable time. And the lesions can also be bilateral. So if you confirm Warthin's tumor in one gland, please definitely check for the other gland. This is the vascularity in the mass. The soft tissue mass are lower echogenicity than the normal gland, but definitely higher than fluid collection. And also my colleagues applied elasto in tumors. This one at first sight it may look like pleomorphic adenoma, and of course the histopathology is the definite diagnosis. Other tumors are less common, and unfortunately many of them, they do look the same, like in ultrasound, like for example mucoepidermoid tumor, and definitely they need verification by histopathology. Due to rich blood and lymphatic supply, also parotid glands are a site of metastasis, and this is a case from literature confirmed as a metastatic lesion in the form of polycyclic, irregular, hypoechoic lesions with areas of hyperechogenicity. And this is also a case from literature. Very rare tumor, malignant pleural mesothelioma, and it metastasized to right submandibular glands with an area of definitely higher echogenicity. So if you see something high echogenicity, think metastasis in salivary glands. And before I wrap up my presentation, let's have a look at some non-salivary glands pathologies where else we can apply ultrasound. For example, this was a patient after excision of small tongue cancer without radiotherapy, without chemotherapy, and he comes for periodic follow-up, and all we see is just the scar in the lymph in the tongue. For the lymph nodes, I'm sure you know the features of normal, inflamed, and metastatic lymph nodes, and you know that it's still not possible to differentiate the inflamed from metastatic or tumoral nodes with 100% sensitivity and specificity, but we do try using different methods. In most of ultrasound scans, we can see some normal lymph nodes. This was group 1A, 1B, and oval a lymph node, hyperechoic fat hilum surrounded by hypoechoic cortex. Then inflammatory lymph nodes, more roundish, lower echogenicity, no normal hilum, and increased vascularity. Then metastatic lymph nodes, this was a patient with oral cancer, again increased echogenicity with irregular, ill-defined margins, irregular vascularization. This is a hint, sign of metastasis. Increased vascularity with disrupted pattern, and in elastography, in this case, you can see that it's hard blue. So the lymph node was hard, and this also corresponded to metastatic lesions. This was a patient who came from overseas to use dental care in Poland when visiting family, and unfortunately we found lymph node packages in the neck, and the patient was diagnosed with Hodgkin's disease. And this was a dental student after extraction of a third molar, and there was inflammation in the masseter with a fistula, and another patient, another case with fistula tract, sinus tract running all the way to the surface of the skin via the masseter muscle and the cheek, also as complication of extraction. And this was a patient who 3 weeks ago had incision of oral floor abscess, and we still see some traces of hypoechoic abscess in the oral floor. For the cysts, apart from the cysts in salivary glands, we can see the developmental cysts from first and second branchial arch, and that most commonly thyroglossal arch cyst, and that's like an upside down digit 8. It was incidental finding, and the patient is under follow-up for this cyst. There is a large second branchial cleft cyst with typical location, and as mentioned before, if you see cystic lesion in parotid gland, think first of an intraglandular lymph nodes. We also examine patients with masseter hypertrophy. This is, for example, control following botulinum injection and the measurements of dimensions. Please remember to measure the muscle and relax and contractions. Trauma, not directly, of course, but for some complications of trauma. This is lip. This was a teenager who fell from a horse. These are reflections from the teeth, and she had a wound in the lip. She had a lot of foreign bodies removed from the lower lip, but still some pieces remained. It was kind of small pebbles inside the lip. And this is long term after trauma, ossifying myositis of masseter muscle with the areas of calcifications, increased density with post-acoustic shadowing within the muscle. Other tumors of the maxillofacial area that we can pick up in ultrasound, for example, it was myoma in the left cheek. However, of course, the diagnosis needs confirmation by cytology and histopathology. This is tongue myoma. Lipoma is a little bit, maybe this one will be better. This is a lipoma on top of sternocleidomastoid muscle. This is a lymph node. This is a common carotid artery. This is internal jugular vein. And a little lesion on top of sternocleidomastoid muscle. We also should apply ultrasound in some vascular lesions, the small ones. I told you about this is this acoustic coupler, so the jelly through which the ultrasound beam penetrates, and there's a small lesion with it's even not power Doppler, it's more sensitive than power Doppler to demonstrate small blood lesions. And there is a vascular lesion which was intraoral near maxillary tuberosity. I was really surprised that it was possible to perform intraoral ultrasounds without gagging reflex. Multilocular lesion with very low, probably very low vascularity because there are only feeding vessels around the lesion. And in some cases, in vascular lesions, we can also see phlebolids, so venous stones, this one in lower lip hemangioma, and this is in tongue, in a large hemangioma of a tongue. So in summary, there are advantages and disadvantages of ultrasound. What is an advantage is widely available and cost-effective. It provides very good imaging of soft tissues with very high spatial resolutions, shows internal structures of organs. It's real-time examination, so you select the parameters of the scan and not your radiographer. You can take the medical history of a patient. It serves as a guidance for biopsies or injections. So far, after 50 years of use in clinical practice, no known long-term side effects. The patient can be examined just everywhere for the head and neck ultrasound without any preparation. And the ultrasound scanners can be extremely versatile. Disadvantages, the ultrasound does not penetrate through intact bone, so you cannot see what's inside the bone unless the cortex is resorbed. As mentioned also before, it performs very poorly with some gas. The depth of penetration of ultrasound is limited by the type of a probe, so the frequency of imaging. The method is extremely operator dependent, so you need a lot of skills and experience to perform ultrasounds. And there are no scout images like CT or MRI. Once the study is done, you can't review it as a whole. You can review only what you recorded. And if you missed some area, if you did not place the probe on top of this area, you will not be able to retrieve the image anymore. And now I would like to thank you so much for your attention with this picture I took in the Baltic Sea in the north of Poland in September this year for the Orthodontic Congress.
Thank you very much, dear Professor. We are here to have any questions if our audiences want to ask. Your presentation was very beneficial as ever, and we can learn a lot about ultrasonography. We wish we can have you here in Iran to give us a course, maybe a 1 week or a 1 month course if you can in the future.
Probably 1 month would not be possible due to my tight schedule, but 1 week maybe it will be feasible for us in the future to meet in person, and I can contribute to the faculty, to the postgraduate students, pre-graduate students at the university with the ultrasounds.
This is a field of many of my colleagues like to know about ultrasonography. We have some weaknesses in this field in our practice. In future, maybe we could have more contributions.
Yes, I'm sure it was, it was within the frames of 1 hour presentation, so it's not possible to put everything in such a lecture.
Yeah. Thank you very much. As I see here, there is no questions, so thank you very much for your contribution. And
Okay, so maybe I will just type in the chat box, I will type my email and the university. So if you have some other questions that may arise afterwards, please do not hesitate to write me. Of course, I cannot promise to answer immediately, but I check my emails on regular basis and try to follow the conversations with colleagues.
Thank you very much.
Thank you so much. Merci.
خواهش میکنم. It means you're welcome.
Thank you so much. You are also welcome if we are able to establish face-to-face contacts.
Thank you very much. I wish so. I may say thank you and goodbye.
Thank you so much and goodbye, and hope to see you soon. Thank you for chairing this session.
So do I. Thank you.
Thank you so much. Goodbye.
Bye. از شما درد نکنه. جانی جیگر دلم ضعف رفته بود که قرب صداقت برم. عین خودته.
دیدی؟
به خدا
خوشحال شدم واقعا.